Here at the Melanin Initiative, we simplify medical information into language you can understand. We create a safe space for you to ask your questions and share our nursing perspective. Today, we'll be talking about the overdiagnosis of pediatric ADHD with our very special guest, Dr. Takesha Leonard. She is a psychiatric mental health nurse practitioner with a doctorate in education, and she's joining us from Buffalo, New York. If you're new here, welcome to the Melanin Initiative. I'm Dr. Kimberly Madison, and I co-host this show along with Alicia and Geraldine, who send their love in their absence. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and then to use it, to manage your health and advocate for others. Our mission is twofold. One is to simplify complex health information so you feel empowered to ask questions, educated on how you can manage your health, and confident to navigate the healthcare system. The second is to elevate the expertise of nurses, like we're going to do here today with Dr. Leonard, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how they can leverage their expertise as both clinicians and entrepreneurs, which again, Dr. Leonard is going to help us do today. If you haven't already, we invite you to subscribe so you can be notified when we release a new episode. Please give us a thumbs up, leave a comment or two, and share it. It helps the algorithm know that this information is important so that when people like you look for content like this, we'll show up higher in the search results. Remember, friends, this show is for educational purposes only. The opinions expressed here are our opinions alone. They are not a representation of any of our affiliations. If you're experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you think you might be having a physical emergency, you should call 911. If you or someone you know might be having a mental health emergency, you should call 988, or you can text 741-741. Ladies and gentlemen, today we have a phenomenal guest, a trailblazer, a healer, an advocate for our community. Now, y'all listen to me when I say this. Our guest today is the real deal. For over 14 years, she's been holding it down on Buffalo's East Side, serving as a family nurse practitioner, bringing care, compassion, and expertise to an area where those qualities are needed most. But she didn't stop there. No, ma'am, no, sir. Dr. Takesha Leonard saw the gaps in mental health care, especially for Black and Brown communities, and said, I'm not just going to talk about it, I'm going to be about it. She returned to school, earned her postmaster certification as a psychiatric mental health nurse practitioner, and now she's leading the charge in primary and psychiatric care. She is also the founder of her private practice in mental health that launched in October 2024, where she's creating a safe space for patients to tackle anxiety, depression, and trauma. She's not just talking treatment, she's building trust and transforming lives. And when Buffalo faced an unimaginable tragedy, she stood firm, helping a grieving community heal in the wake of a mass shooting. But that's not all. She's a medical director, a mentor to high school students of color aspiring to enter the medical field. She's got the academic credentials to match: a doctorate of education, health policy and administration, advocacy, education, community, leadership. She does it all. So buckle up, because we're about to have a conversation with a powerhouse in the field of healthcare, a champion for our community, and someone who's as brilliant as she is compassionate. Please join me in giving a warm Melanin Initiative welcome to the incredible, incomparable Dr. Takesha Leonard. Yeah. Welcome.
Well, thank you. Wow. Okay.
That's a lot of fun.
Yes.
Shannon Sharp for showing how fun it is to give people their flowers.
Absolutely.
Before we get into our conversation, we're going to do this thing we just started called 5 Questions in 5 Minutes. Credit goes to Nancy Twine. She's the host of another podcast called Maker's Mindset. So the idea is just to give us the quickest answer so we can learn about you. So the first one is, what is the next big idea you want to be a part of?
An advocacy center in Buffalo, New York.
What would you do if you could do anything for free?
Open up a church.
Okay. Is this a special church or a church we're familiar with?
A church I'm familiar with, but making sure that it has a stable housing unit is what I would say.
Okay. If you had to start over, what would you do differently?
I would have more children.
Ooh. And can you share with the audience how many children you have?
I have 5 boys.
And a husband.
And a husband.
And that other child, you were hoping just for a 6 or a
It
girl?
would be a girl. It would
Oh, it
have to
would
be.
be. It
Yeah,
would
there's
be.
no option.
And who would you like to give their flowers to?
Um, so there's so many, but right now I would say my pastor. Her name is Pastor Cheryl Roberson. Just quite an inspiration, just uplifting, just a woman of God, and I truly love her. So that's who I would give my flowers to. Give her flowers.
And you said this is Pastor Robinson?
Cheryl Roberson.
Robeson.
Yes.
Well, Pastor Cheryl Robeson, if you're listening or watching, this is an open invitation to come and be part of our Faith in Medicine series where we answer the tough questions. So, hope to hear from you soon. This last question, you're welcome to take a little bit of time with.
Sure.
We would like to know, what season are you in?
So right now I am actually in a season of growth. And I know that sounds a little bit crazy with all that we've talked about before, but I'm in a season of growth and kind of finding my path. Yeah, so even though I've done all these things, I'm still kind of searching for that thing that I feel like God has truly called me to do. And I think I'm almost there.
So I'm curious, when you got your graduate degree as a psychiatric mental health nurse practitioner, and when you got your doctorate degree, did you feel like you were there then too?
I thought so. But then things change. I mean, that was the season where I thought the community needed it the most, and they needed people that looked like them to provide mental health treatment, medication management, especially because there's not a lot of access. But now, as I look at advocacy and a broader picture, and just looking at the laws, administration, and all the things that are near and dear to my heart with my patients and my clients on the east side of Buffalo, Black and brown, but also I take care of a huge immigrant refugee population. My season is changing, and now I'm thinking like, I need to be using my voice to speak out, to advocate for, health equity, to promote diversity in medicine, and just to be a voice for the people that, often feel pretty voiceless. So, yeah.
A voice for the voiceless. And so for someone listening, how will they know when they've found their purpose?
So it's something that's like, it's kind of internal. It's just like you just feel settled in what you're doing. So, for me, I know that it's not done yet because I'm still striving and I'm still looking for areas to grow. I'm still putting myself in places where I feel like I can be a help, or I can, kind of, lend support. And so I feel like when that time is done, you're going to sit back and say, okay, and now I have poured into the next group of leaders that can take my space, and now I can sit back and just invest in them. And I'm not there yet.
Okay, thank you for sharing. So let's get into it. We have a really big topic today. It's a very popular topic in our community, and certainly there's a lot of questions and not always a lot of answers, especially with people who look like us, for people who are impacted by this. So we want to thank you from the top for sharing your time and talent, not only with us on the show and the audience, but all the work that you've done that you're going to be sharing with us today. It really means a lot to us.
Thank you.
So how do you define ADHD or attention deficit hyperactivity disorder to your patients?
Okay, so attention deficit hyperactivity disorder is a neurodevelopmental disorder, and it presents differently for everyone. And so I know that the primary characteristics are usually that hyperactive, impulsive. Usually, it's in a child, but that can be along a spectrum. So it's broken down into two categories. So you have your inattentive type, and those are our kids or even our adults that just have trouble focusing. They're very distracted. They can't concentrate. So those are the kiddos that are getting calls home from school, like, he just forgot to hand in his assignment. Or, we went over this chapter and within an hour, I asked him questions about it and he couldn't recall anything. Or, he seems to be daydreaming a lot. And I'm just saying he, but it could be she. They, them. So, I mean, all, it just kind of goes along the spectrum. And so then you have your impulsive hyperactive type. And those are the the students and the adults that people are used to fidgeting and they're moving and going. And these are our disruptors because now they can't sit still. So they're getting out of class and they're not raising their hand because when the teacher asks a question, they're very impulsive. So they call out the answers. And so it's broken down into those two categories. But the third category is the combined. So then you have your distraction, your lack of focus and concentration, and then you also have your hyperactivity, impulsivity. And so again, they vary across the spectrum. So you can have a mild case of it where, there's just little hints of it that you can see here and there that maybe people will miss because they'll say, oh, that's just the way, she is, or that's just the way they are. And then you have those that you're looking and you're like, yeah, this is a major issue. The thing is that according to the DSM-5 criteria, it has to occur in at least 2 or more settings. So if you came to me and you said it only happens in math class where he just seems really distracted, not able to keep up with the work, but at home, at church, with his friends, when he's with family, when he's out, having a good time, nowhere else am I seeing these behaviors. That, yeah, he has a lack of focus in that class for reasons that we have to delve into, but that's not ADHD. And then how does it negatively impact their quality of life and their ability to do what they need to do? Are they failing all of their subjects? As adults, are they showing up to work late? Are they handing in their assignments? Are they forgetful, disorganized? They can't keep up with normal day-to-day activities. And so, and again, that varies across the spectrum. The thing about it is that we all have these symptoms at some point, but normal people without ADHD are able to bypass and get over it. If you have ADHD, it is incredibly difficult for someone to tell you, I need you to sit here and focus on this exam for you to do that. And so that's how, you define it.
Beautiful. And I love that you broke it down into the 3 areas too. And you gave a beautiful way, helped us really picture what that can look like. And I mean, even when you were talking, I was thinking of myself, particularly as a little girl, because I had issues with comprehension. And you had mentioned the daydreaming that continues. So yeah, you piqued my attention there. You mentioned a vocabulary word. We love to go into vocabulary words here on the show. I recently recorded someone, we've talked about it, but I think it can't hurt to talk about it enough. You mentioned the DSM-5. Can you tell us what that is and how important it is to your practice?
So that is the Diagnostic Statistic Manual. I'm trying to see if I have mine out for diagnostics. So for diagnosing any mental health or psychiatric condition. And so we use that as kind of like our Bible for diagnosis, because if it fits within that category, you can pretty much say, okay, this is what this client or what this person has. And so they give you really, really, really specific guidelines. And it helps us because then we can rule out other disorders using that criteria. And so that is the number one, reference that we use in order to make diagnosis.
I heard you say mental health and psychiatric. So are those different?
So yes, because you can have a mental health disorder and you're dealing with mental health, and sometimes that's just dealt with maybe your counselor or, and then psychiatric is where I come in. So I don't do a lot of counseling or a lot of psychotherapy. There is a component of psychotherapy that I do in my practice, but most of it is psychiatry, which is more medication management. And so that's where I predominantly kind of step in. Now, the thing about it is that I always tell my clients, it goes hand in hand. I don't make the criteria. I don't set it that you have to have a counselor in order to see me, but I strongly recommend it. Even for our kids with ADHD, which is a neurodevelopmental, mostly behavioral condition. Going to counseling helps them develop tools for organization or tools to learn how to deal with, when they're feeling impulsive, how do we settle ourselves down naturally? What kind of tools can we give a child so that they know, okay, I feel like I'm escalating. I feel like I want to do something. And how can I internally just kind of settle myself down before it gets to escalates to a point where the teacher has to, kind of speak to me. So I always say mental health and psychiatry because I do believe that they go hand in hand.
And when you say psychotherapy, that's the same as talk therapy, right?
It is. So it's counseling, so CBT, which is cognitive behavior therapy, DBT, and all of those modalities. And depending on what the client comes into, the clinician will decide, or the counselor will decide what modality should be used for that child. But I always believe that, psychiatry and medication plays a role, but that counseling component is so important.
DBT, is that dialectical behavior?
Therapy. Mm-hmm. Yes.
Dr. Ani Adabang, she was here. She mentioned it briefly. And you guys just be throwing out these vocabulary words.
Okay.
I was telling our in-house trauma therapist, Kelsey Wilson, who sees patients in Virginia and DC, girl, you need to just come up with a vocabulary book just so we can follow along when you give us these suggestions.
I agree. And there is a lot, because then there's solution-focused therapy. And I think the benefit is that although I don't study specific therapies, that I am familiar with them. So when I'm speaking to my clients, I can suggest, based on your symptoms and what you're bringing to me, this is the medication that I feel like I can prescribe for you. But there is a therapy that can help you kind of deal with these other issues, EMDR for trauma. And so, it's just nice to be familiar with them. So not being able to kind of do them yourselves, but being familiar enough where you can talk to your clients about them.
Yes, and you can refer to our mental health playlist where we have talked about EMDR with Kelsey.
Wonderful.
Desensitization reprocessing.
Hi, I'm Alicia from the Melanin Initiative podcast. Our mission is twofold. One, to simplify complex health information so you feel empowered to ask questions, educated on how to manage your health, and confident to navigate the healthcare system. And two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. In less than 2 years, we've grown to over 50,000 views and 1,000 downloads, with an international audience spanning the US, Canada, the UK, Australia, and more. Our engaged listeners are professionals, entrepreneurs aged 25 to 44 who value authentic, impactful content. Want to connect with this dynamic audience? Advertise with us. Send in your 1-minute video ad and let's amplify your brand. Email tmi.melanin@gmail.com for rates and details. Let's work together.
I think that's it. That's it.
For breaking that down, because now I understand why you're called a psychiatric mental health nurse practitioner, because before I thought it was kind of just like saying the same thing twice, but you just explained the difference.
Absolutely. So there is a component of it. And we do a level of psychotherapy, and that's part of our training process. But if I feel like we're kind of going beyond what I can provide, I'm always referring out. And the benefit is that when you do this work and you are out in the community, Dr. Madison, you make connections with you are intentionally making connections with other clinicians. So now we have formed a little pipeline where we can refer back and forth. And so that has been an amazing part of this journey as well, is that I have clinicians in the community that I can lean on and get support from, as well as, they can lean on me and get support when it comes to medication management. So, don't just kind of stay in your bubble, kind of, get out there and try to find resources out there for your clients that will be, helpful to them.
That's wonderful. And you I think you do a really great service, because you can write prescriptions, right? And a lot of the public thinks that's all we want to do is write prescriptions and send them out the door. But you have spent quite a bit of time just explaining how important you think the talking through it is. Absolutely. Which I think a lot of people might be surprised. I know, because patients have told me directly that they think we're just here to give them medication and not solve their problem, right? That's what they're complaining about. Well, nobody's trying to solve my problem. And you have explained, like, no, I think that's important too.
Absolutely. And when you're thinking about the diagnosing of ADHD and the assessment that's necessary to make that diagnosis. So, a lot of times what I'll get is a client that has come in with a parent, and the teacher has said, I really believe, that, Timmy has ADHD. And mom is saying, well, the teacher said that this is what's going on in the classroom. So this is when we talk about overdiagnosis, what I see is overdiagnosis of ADHD in kids that don't have it, and underdiagnosis underdiagnosis in ADHD, that kids that actually do have it. And the reason for that is that comprehensive assessment is so important. If you don't have the hour or more to dedicate to actually doing a full evaluation on that child, please send them somewhere where you can. Now, a primary care provider can absolutely do it. As a family nurse practitioner, I can absolutely do that comprehensive assessment. In the system that I work in, which is a FQHC, is there time to really sit and spend that hour with that child? It's not very likely, And so, I need to know that if I give that child a diagnosis that will likely follow him through the rest of his life and education, that I want to be pretty sure that I've done my due diligence in making sure that that diagnosis was accurate. And so in my private practice, which is one of the things I love about it, is that there is that hour that I can dedicate. So we are going over birth history, family history, because there's a huge correlation between ADHD and genetics and hereditary. Like it's a very huge correlation. We go over medications. Have they ever been on anything where they ever experienced lead toxicity? How are they sleeping? Does your child snore? Pediatric obstructive sleep apnea has been linked with symptoms of ADHD, and we're diagnosing ADHD, but we miss the component of sleep. When we're tired, we do weird stuff. When we're tired, we do things to keep ourselves up, to stimulate our brain. So we're moving, we're doing, as adults, we're doing that. We're trying to keep ourselves up. And so these children are being diagnosed with ADHD without knowing that they have been snoring for the past 4 years, and, they might have sleep apnea. And then we talk about, did they meet all their milestones where they were born? Were they born on time? And this takes time. I recently had a parent come in with a client, and 11 years old now, and he's totally struggling in school. And teacher, of course, made the initial suggestion, there's something going on. But what this kid told me is, Ms. Keisha, I don't want to go to school anymore because I'm not as smart as the other kids. And so we're sitting there and we're going through the whole history, and mom starts crying. And I say, well, what's going on? And she says, because you're describing me. She said, they just told me I didn't work hard enough. I need to put in more effort. And she's like, I never, ever thought that this could be a thing that maybe I had. And now he's displaying the same symptoms. And so that history and that comprehensive assessment is essential. It's just like sending someone for a mammogram and you find a lump on the mammogram. You don't automatically diagnose them with breast cancer. You send them out, you get more testing, you send them to a specialist, they might need a biopsy. Before you come to that major conclusion or that major diagnosis, you do your due diligence. And so I noticed that in some of my kiddos, that's not being done. And they're coming to me on medication that is not working. Well, because they never had ADHD, but they did have sleep apnea. They struggle with some anxiety. They had some trauma. But then I noticed the opposite too. The studies are kind of conflicting with that, Dr. Madison. So there are some studies that show that our Black and brown kids are very much underdiagnosed with ADHD because they have behavioral issues. So they're more likely to be diagnosed with oppositional defiant disorder. They're defiant and they're mean and they're disrespectful, or conduct disorder, and they're hitting and biting and doing things. And so there is a huge health disparity there as far as most of the studies are showing. But what I do notice, Dr. Madison, is that's changing. People are talking about their mental health now. People are seeing that there are things that are not right with my child, and I want to seek attention. I want to seek medical attention for this. I want to get evaluated. So in my own practice, and just being on the east side of Buffalo for 15 years, I noticed that our students, our parents are more empowered to talk about mental health because they are seeking help. They want to get help. And I'm just glad that I can be a part of, that solution. So I know I said a lot, so you can stop me anytime, Dr. Madison.
That's okay. You did a wonderful job explaining. So, our topic today is the overdiagnosis of pediatric ADHD. And so you talked about what an accurate diagnosis looks like, which is a comprehensive assessment, which typically takes an hour. You gave some examples of what kind of questions are going to be asked during that assessment. And one reason that overdiagnosis is occurring is because people aren't taking the time. They don't have the time. They're not taking it. They're making kind of rash decisions. You mentioned that you work at a federally qualified health center. And in those settings, and like many settings in our system, we simply don't have the hour to make that appropriate diagnosis. And so you're pointing out some of the contributing factors as to why we're seeing this overdiagnosis. And so you did a beautiful job with that. Curious, what do we know and you mentioned this trend and people wanting to talk about mental health. And this is in the literature. We're seeing that people are doing that. They're going to social media before and after the visit, one, to ask, to kind of find out what's going on with them and to find ways they can treat it. Then after they come and talk to a professional like you, they're going back to see if you were right and if other people are in consensus. And that can only, if they're going to come to social media, we need to be here too. And
Absolutely.
so today is a wonderful service in addition to what you do during your day job. So I'm curious, what causes ADHD?
So there are several factors. I mean, and again, the research is out there. So there's a huge genetic component that they're saying, they said, so they looked at twin studies, and it looks like there was a 70% like correlation between twins, even if they were separated, that they would both have ADHD. So there's some genetics, there's some environmental. So, the likelihood if you grew up in a home with parents or with the siblings that had ADHD, that there's a high chance that you might have it. And that goes for a lot of other mental, health or mental health diagnoses as well, Dr. Madison, because if you think about it, when you get a diagnosis or when you're a certain type of way or you're dealing with a certain mental health diagnosis, you alter your environment to kind of fit the diagnosis. And kids are like sponges. We are their first teacher. The parents are their first teacher. So when you're in a high stress situation, how do you deal with your stress? If you're a screamer and a yeller and, you get really, worked up, the likelihood that, your child is going to be a screamer and a yeller and get all worked up. I mean, even for myself, I would say, growing up in that environment where, I grew up with a lot of strong women. And when we got upset, we were screamer and yellers. And when I got married, I was a screamer and a yeller initially until my husband was like, hello, like this has got to change because then our children are going to be screaming and yellers. So when you grow up in a certain environment, your environment is structured around whatever that diagnosis is. And that can be depression, anxiety, bipolar disorder, schizophrenia, ADHD. And so so I can't say that there's any one specific reason or one specific cause of it, but there's several. It's multifactorial, just like most mental health diagnoses are.
And do you happen to know any of the current statistics or prevalence and incidence rates when it comes to diagnosis?
So there are about 7 million children in the US that are diagnosed with ADHD. And that last study was as of 2022. I'm sure that it's a lot higher now. And one of the reasons is because people are recognizing it now. I mean, I am getting adults that are, successful, that are, are working and doing things in the community and things like that. And they come to me because, you know what, Keisha, I've always been told that I just had to work harder. And so I did. Life was so hard for me to get through this. If I knew that I had ADHD and I was diagnosed and treated, I would have been a better student. Not that I was, I didn't fail anything. And so, people are looking at ADHD like, well, those are the kids that, fail everything. I mean, you made it through elementary school, middle school, high school, maybe possibly medical school and all of that. There's no way you had ADHD. But how hard was that life and that track? Because that focus and attention is off. So inside of our brains, and I'm not going to get too much of the neuroscience of it, is that dopamine. And in ADHD, that dopamine, norepinephrine, all those neurotransmitters are a little bit lower. And so that's your, your executive functioning, that's your emotions, that's your ability to concentrate and, look and see and do. And so what happens is you have to work extra hard when you have ADHD in order to do that. In the meantime, without that diagnosis, you're being told, well, you're just not as smart as your brother, or you need to work as hard as your sister, or, or maybe, you need to study more. And what the brain is saying is that if it doesn't interest me, it's not stimulating that dopamine, I can't do it. But I can play this video game because the lights and the actions and the instant gratification, and that's happening. And so you get that too. There's no way he has ADHD. He can play video games for 2 hours. Well, what does a video game do to the brain? It's a stimulant, right? It's stimulating. Calculus is not stimulating. I guarantee you it's not stimulating. So we all have periods where we just want to dull out. If we all, I mean, we went through nursing school, we went through nurse practice, all them theorists that we had to learn about and all the theories and all that. I mean, but I need to pass this exam. So for us, we can bypass it. We're going to study harder. We're going to put in more work. When you have ADHD, it's almost impossible to do that. And some people will push past it and they will struggle and work so hard and they will get there. And then they come to me, and because someone said, but you're in medical school, like you don't have ADHD. And I'm looking at that history and I'm thinking, no, we missed it, love. We missed it. And now we can do something about it. So.
Yeah, you did a great job talking about kind of the disparities we see across different racial groups. What about socioeconomics? Are there any differences there?
Well, I mean, so the studies, again, I read a lot. So, the studies are showing, of course, that there are differences and disparities in socioeconomic status, but what they're relating it to is lack of access. And, which is why I'm here, and which is why I encourage, all of our listeners to be out in the communities, where the need is the most. I mean, the most rewarding part of my job is that I know that I am necessary and I know that I am needed. We'll talk about, the pay later, but right now I am necessary and I am needed. And so that's why I'm here and I'm going to do this job. But even in my primary care practice, just getting my clients into a specialist, when they don't have, the commercial insurance and they might have the Fidelis and the Medicare or whatever, it is the Medicate. It is hard. It is very, very difficult. And that's the reality of what this is, of what our society is, what our healthcare system is. But what that means is that we need to create more of us. We need to create pipelines to build people that want to stay in communities that they grew up in and they want to give back. And so, yes, you will see it. Health disparities in socioeconomic, like in impoverished communities, but it's most likely related to, or more than likely, it was related to just lack of access. So I know that my child has these symptoms, but the likelihood of getting an evaluation, and especially with someone like a neuropsychiatrist or neuropsychologist, it can take up to a year. It is almost virtually impossible. So what do? We go back and we learn. And we learn now how to do these evaluations and how to do these comprehensive evaluations. And then we bring them back to the communities where the need is the greatest. And we can all play a role in, in helping, with health disparities and in the ways that we can. I don't feel like we can eradicate it at this point, but I feel like if we keep pouring into our communities and pouring into our healthcare system and creating pipelines to build up the next generation of providers, we're going to get there. I believe that.
Okay, so when it comes to access to care, it seems like you're really big on creating that access in people, right? You talked about being in the community, a pipeline. I think you're referring to your mentorship, kind of mentoring that next generation of clinicians, right? Is there anything else we can do when it comes to increasing access to care that includes humans, but also maybe some tech or some other professionals that are out there?
Well, things like this, Dr. Madison, you are a golden star right now. I mean, just spreading awareness, bringing people like myself. And I mean, I've watched tons of you are already creating a platform for people to speak about these things and talk about the need in communities that really, that are struggling. I hate to say impoverished communities because when I'm in my system and I'm in my practice, the love and my patients don't feel impoverished because they're full of love. But when I speak of impoverished communities, I mean lack of resources and lack of access. And so, I mean, using our social media, using our voice, being advocates, not being silent when you see injustices in the healthcare. If I just as an example, I have African-American man, maybe 56 years old with a developmental delay. He sees a cardiologist, a significant cardiac condition. He comes to see me about 6 months later, and the cardiologist dismissed him from the practice. Why did he just see? Well, he said I didn't show up, but I can't really remember my appointments. Mr. Keisha, you send me a reminder. They didn't send me a reminder. So I got on the phone with that cardiologist and said, no, we're not going to. It's his heart. He needs that. So we're not just going to dismiss him. And did you know that he has a developmental delay? Did you know? And the cardiologist he apologized. I mean, gratefully, he took the patient back. But how did we miss that? So now I'm sure that cardiologist is going to think the next time. But if we just sit silent and we do nothing, it doesn't help our system. So having platforms like this where we can speak about health disparities and then talk about what we're doing, that pipeline starts with high school students. I'm noticing by the time, they get past high school, they're just ready to go and do other things, or maybe they have not even made it through high school. So I start at 10th grade. That's where the high school summer program starts at, in 10th grade. And we go all the way up to 12th grade. And we give them 6 weeks of intense learning. They shadow me in the clinic and actually see patients with me. UB Medical School takes them into the hospital and they shadow medical students that look like them. They get a Black or brown mentor that takes them through the community and shows them what does it feel like to be a medical student, a provider, have culturally sensitive healthcare, to talk to your patients. These students are learning lessons that people don't learn until, they are actually in medical school. And what I notice is that they come back and they are empowered. And then at the end, Dr. Madison, the best part is that we have a white coat ceremony. And so I have all the parents come up and white coat our students, and they have these big coats on, but they are walking in it and they're feeling it. This is just a little taste of what could happen if you continue to pursue your dreams. And then I let them know I am here. So yeah, use me. So.
I do have to, I'm here in Houston now, and I have to give a shout out to 2 organizations. The National Black Nurse Practitioner Association had the pleasure of meeting at their annual scholarship brunch. And one of the other guests is Dr. Geraldine Young. She's the founder of Diverse Coats Society. We'll have her on so you can learn a whole lot more about her mission, but it's an interdisciplinary society because there's so many of us who provide care, right? Mm-hmm. And to represent that diversity, their logo is a black coat.
Oh,
so I'll just say a little bit that she told me. So if you think about our history, white is always seen as good and positive, and black has always been seen as bad or negative. And so have you ever asked yourself, why is the coat white?
I have not, but I'm thinking about it now, Dr. Madison. I mean, that is an excellent point. Excellent.
That's the same thing you're feeling right now and thinking is the same thing I went through when I sat at that table with her. And I said, I never thought about it.
Nope.
So just putting that out there.
I like it. You might see something different.
And I do, and so you can go on their website and you can purchase a coat. And so once I get mine, I'll wear it on this show.
That's awesome.
We are going to have her on this show too, so she can tell her own personal story.
Wonderful.
But we love what you're doing. We love how you're giving us actionable tools that we can use, and you're giving us ideas on how we can use our expertise and share it with the next generation, the impact that can have. Let's see. So what about some systemic biases when it comes to diagnosis, and particularly actionable steps we can give those teachers and parents who have the pressure to address behavioral challenges rather quickly?
Yeah, so it's hard. And it is tough. I'm a mom. And so, it's hard to hear that your child is not doing the best, especially when it comes to school, because really that's their job. That's their primary responsibility, is just go to school and do well and let mommy and daddy do their job so that we can take care of you. So when you get that call, it's almost like a dagger to the heart, because what it does, and a lot of times, is you reflect on it. What does that mean for me as a parent? And if you're not thinking of a neurodevelopmental disorder, then you're thinking my child has behavioral problems, or the teacher said he just calls out. And if you're not familiar enough with, like, let me make sure that I'm getting evaluated, you internalize that as a parent and you start thinking, what could I have done different? What did I do wrong? And then what happens is, when child comes home after you got that call, now you're upset with the child. What happened in school today? And you're not doing and you're not doing great. And, teachers have 30 students in the class. And so if your little guy is disrupting the entire class, then that means all of these other kids are missing out on their education. And so teacher has an obligation to call mom, especially if it's repetitive behavior. And then mom is trying to figure out, okay, what do I do? And what does this mean for me and my family? The issue is that sometimes we have to think about the school environment and what is conducive to a child's learning. So, many, many years ago, and when I was in school, there was a lot of sitting, sitting, lecturing, listening, and that is the way we were pretty much trained. Sit, lecture, listen. You just hear, and you feedback, and kids these days need more room. Dr. Madison, they need room to breathe and to think and to develop, and they need to go outside and need fresh air. So to tell a child with ADHD that I need you to sit and watch this lecture, and then at some point be able to relay and kind of spill out that information is virtually impossible. And if you don't know that child has ADHD, and now he is bored, so he might be a little more disruptive, and now he's got labeled, now he's a bad kid, or, he got removed from the class and down to the principal, whatever. And so now teacher is calling. A lot of times when I get my kids in, it's because the teacher is the one that actually already made the diagnosis. But then I said, well, if a child can't teach the way you learn, then, if they can't learn the way you teach, why don't you teach the way that they learn? So it is not uncommon for me to call the teacher, or to go into the classroom and just talk to the teacher about, like, what is the learning style here? And sometimes, Dr. Madison, if you sit in the classroom, you'll notice you don't want to sit in that classroom. I mean, it's hard for you to stay focused and paying attention when it's just, so why don't we create systems where we're all working together? The student, the parent, the child. Let's look at kids as individuals. Let's be more aware of what our child needs specifically to help them grow and learn. And then let's do something about it. And I will give you an example. My little guy has an auditory processing disorder. And so what happens is that he can get the information in, but it just takes him a while. It's got to process, and he can't just spit it back out. So if you tell him something and then you ask him a question, he's not going to be able to give you that answer right away. You come back in a little bit later, and he is going to be able to give you that question, but you can't ask him right away. I noticed that at home too. Didn't really make the connection. I'm just like, hey, come on, let's, we gotta. And so we took them and had them evaluate it, because I can, and I know that. And what they did was they gave him a little earpiece that sits in his ear, and he's got dreadlocks. So you can't see it. It's covered by his hair, and it drowns out all the noise around him. And so the teacher is specifically speaking to his little earpiece. And so therefore the distraction is less, so that he can process quicker. That is what I am talking about. And we can advocate for things. I didn't know they had something like that for kids, where they can design that for him. The only thing my little guy said is, I'm not letting nobody see this thing in my ear. So I made sure that we kept his locks nice and long and covered. But if they can't learn the way we teach the way they learn. So let's look at the entire system and see how we can make it most conducive for these kids to learn and be okay.
Beautifully explained. That's a t-shirt. Teach the way they learn. I love that. That could be like a whole program. And actually, that's my next question. Do you see, because you said you go into the classroom, do you ever talk to like the whole teacher, faculty, like at the beginning of the school year? And that could be.
So I have not.
Teach the way they learn.
I mean, it's so, this is so helpful for me. First of all, the black coat, I'm still thinking about that in my head. So I gotta, I gotta get back to my focus, because that is absolutely amazing. But no, I haven't. But the thing about it is that, why can't we and why don't we? I do have individual conversations with teachers, and that's fine. But why not have as a provider, as a psych NP in the field, why not have workshops where teachers can come and learn from us, and I want to learn from you. Like, so what are your tools and your techniques, and how can we modify them so that they meet the needs of these students that are struggling the most? So I think there's always opportunities to collaborate and to learn. We're all here to do what's best for the child. That's what we're all here for. So, and that takes the parent, that takes the child doing their work, that takes the provider, that takes the teachers, the communities, the churches. It takes a village, it takes a country to raise children, and so, yeah, I think that's an amazing idea.
Yeah, because when I think of teachers, I think they have the same struggles we do as nurses and clinicians, that whole, the population, the time constraints, but the needs are so great.
Absolutely.
And then just having the tools, right? Because there's research being published every day, but if you're busy taking care of patients and students, you just don't have the time to read about it. So when we create little opportunities like this, it can be super helpful. I got the idea because one of my DMP classmates, there's like you know how we do CPR? There's like a mental health first aid, and there's a train the trainer program. So you can go learn individually as an individual, but you can also go and teach. Like, oh, that's what she did for her project. She taught the whole faculty how to implement mental health first aid. And so that's where the idea came from. So shout out to her.
That's amazing. That's amazing. But this is why we're doing this, Dr. Madison. Like, this is why it's so important that we bring, clinicians together and talk about what are we doing in the fields, and what can we learn from each other, and how can we take that back to our communities and just serve them a lot better. So yeah, that's amazing.
Yeah. And so to help our teachers and our parents, who's qualified to make this diagnosis?
So again, it can be a family nurse practitioner. It doesn't necessarily have to be a specialist like myself of the time constraints, but psychiatric nurse practitioners, physician assistants, neuropsychologists, psychiatrists, so not counselors. They're not allowed to make that diagnosis, but then they can support you in that diagnosis with their feedback. And so, so the time is really what it is. So you can be a professional licensed, but as long as you have that time to dedicate to making an accurate diagnosis, then absolutely, yeah.
And what are some differentials that you go through when you consider?
So definitely generalized anxiety disorder. There's a lot of overlap there. If you feel anxious and you're all worked up and you're all stressed out, the last thing that you're going to be able to do is concentrate on your schoolwork. There is obstructive sleep apnea, which we talked about, that with the sleep, or sleep impairment. It doesn't even have to be sleep apnea. It can be sleep impairment, like disruptive sleep. So, the young kid now has a little brother that was just born, and now we have a newborn at home that wakes up several times during the night, and this kid is constantly waking up during the night, because the baby is waking him up, or the dog is barking, or, for whatever reason. So it doesn't have to be sleep apnea, but sleep impairment. Are they depressed? Are they sad? And now, and are they irritable because of that? Because they can't figure out what else is going on. Are they anything? And this is what's important. What's going on at home? Is there anything that's going on at home that might impact this child's behavior and, the way he's acting, or the way he's, he can't focus, or he's not paying attention? Because there's other things that are right now more important in his head than this right here. All of that comes with that comprehensive assessment. So as long as you have the time to dedicate to really kind of dig into what's going on with this kid in his life, internally as far as like the home, and externally as far as his environment, then you can absolutely make that diagnosis. The Vanderbilt scales are screening tools that you can give to the teachers. It's a series of questions that talk about behavior, focus, attention, things like that. And so the parents get one and the teachers get one, because remember, we want it to be in 2 or more environments. So we want to know what the parents' perspective is and the teachers. But again, it's not diagnostic. That's a screening tool. A screening tool tells you this is abnormal. I need to look further. Just like the mammogram or the pap smear. This is abnormal. I need to look further. So it's a screening tool. But that comprehensive assessment is where it's really at.
And that's Vanderbilt.
So it's a Vanderbilt scale. Vanderbilt.
And it's screening for ADHD?
It is, correct. And so there's a parent version and there's a teacher version. And then one of the best parts about it is that there's a teacher and parent follow-up version. So after, if you decided to initiate medication or some sort of treatment, you can send a follow-up assessment and see, did the behaviors get any better? Do you notice any difference? And that kind of helps guide you to see what you need to do to modify your treatment.
We love stuff we can look up.
Absolutely.
Our patients, they love that. I have a lot of patients, particularly in communities of color. They want to do the research. They're either coming in with it, or once I bring up something, they're going to go and do it. And I've had some colleagues say, I just talked to my patient. Yeah. And your patient then comes to me and says, look, that's not enough. There's so much data out here showing that the conversation is not enough. People only remember 30% of what we say. And if you've already given a diagnosis of something that's going to cause an emotional response, they don't hear you anymore.
Very true. Very true.
Language is complex. You're in a rush. They're stressed. they don't hear you. They want to go home, digest the information, share it with their loved ones, compare it with other things. They need handouts that they understand,
Absolutely.
that they can take home with them. That's really important. It needs to be in their language.
Absolutely. And you know what, Dr. Matt, I love that though. I love that they're doing more research. Like they're coming to me with questions that I was like, I don't even think of. And I tell my clients all the time, listen, there is no one size fits all. This is my recommendation. I want you to go out there and I want you to research what I'm saying. But if you come back to me and you say, Mr. Keisha, I've heard this, or I've seen this, or my brother does this, and I think this works better, let's talk about it. It is always a partnership. It's never Ms. Keisha pushing medication on you. You are in charge. I put them in charge. Even as young as 7, 8 years old, you are in charge of your mental health. So I want you to tell Mr. Keisha how you're feeling. Like, what does this medication make you feel like? Does it make you feel bad? Does it make you feel good? One of my little kiddos, about maybe 7 or 8 years old, he said, I don't like the way he's on a stimulant. I don't like the way it makes me feel because it makes me feel too calm. That's what he said. And because he was so used to being hyperactive and overactive and stimulated, he's like, I don't like this feeling of calm. So I said, well, why don't we negotiate? So we need you to be calm in school because I need you to get your work done. You like when you get good grades, right? Yes. So why don't we not take it on the weekends? As long as it's okay with mom and dad. Why don't we not take it on the weekends? And so you can still have all your energy, but during the week, okay, so that's a compromise. But that was from a child who just said, I don't like being calm. I like being, all over the place. And so just having those conversations, I love that people are researching and looking into things. It's definitely very helpful.
And I love that you followed up on what we can call non-adherence, right? We don't want to use the word non-compliant anymore because so many times we'll hear someone, with some resistance and then we stop there. They refuse, they decline, they're not interested, they're non-compliant. Okay.
Right.
You inquired further because I believe there's always a reason. There's always a reason they're saying whatever they're saying, what they're doing, and you're not going to know unless you ask. And
Absolutely.
you did that, and you found out something that works.
Mm-hmm. Absolutely, so important. Yeah,
it's for our students as well as our experienced clinicians who might be a little bit jaded. Just a friendly reminder: just ask.
Absolutely, it's really important. And it makes your relationship a bit stronger, and it builds that trust, and that's important. Absolutely,
that's 90% of the job. So what kind of treatments do you offer or are out there for children?
Okay, so of course I talked about the behavioral modification. Let's try to talk about some organizational skills. Let's try to talk about putting things on your calendar. And some of my teens will be like, well, I don't look at a calendar, but you look at your phone. How many times a day do you look at your phone? And we have alerts on our phones that we can set. So we talk about the behavioral modifications because that is important. And then we talk about medication. So now we have the diagnosis. You have ADHD, you have whether it's combined, inattentive. So the first line of treatment is a stimulant. Now people say, oh my gosh, a stimulant. They're already stimulated. But no. What a stimulant does is it stimulates that neurotransmitter that's a bit low in the brain that we talked about. So the dopamine, norepinephrine. And so what it does is it gives them a boost. And so once we boost that in the brain, it allows them to concentrate. So those executive functions are doing a little bit better. So that is the first line of treatment. Now, of course, Dr. Madison, we have to be cautious. Stimulants are addictive. Stimulants can be abused. So, people do things with stimulants. So we have to be, cautious and careful. So I explain all of that to, our, even as young as little kids, like you can only take this when mommy or daddy gives it to you. So you can't go and take this on your own. So it's really important. We talk about the side effects, like the lack of appetite sometimes, because I'll tell you, some of my kiddos will not take that medication because they can't eat, and they are trying to bulk up, and they do not like looking like little bean poles. And Mr. Keisha, I'm not taking it. It doesn't let me eat, or they hide it under their tongue. Their mom is finding it behind the couch and all that stuff. And so that is the child telling me, I'm not going to take this medication if this is a side effect. I am not willing to deal with this side effect. And think about it, as adults, there are certain things we're not going to take. If you know the side effect is you're going to have chronic diarrhea and vomiting, your eye's going to go left, you're going to say, no, I don't care what it does. I'm not going to take it. It's the same. So we have to respect that child. Okay, you're not going to take it. So now let's talk about non-stimulant medications. So not the first line treatment. They pretty much boost the norepinephrine. So still the executive function, it takes a little bit longer to work. The studies show it doesn't work as good, but it's still a viable alternative. And so, and then we have the appetite suppressant is a lot less. And so we try one thing, which is the first line treatment, FDA approved for the kids. And if that doesn't work, I'm always open to like trying something else. And sometimes if I need to, I'll try a combination. So for example, if things start getting a little rough, then I'm like, okay, maybe we need that second dose, which is why it's important that you're following up with these kiddos. Do not put these kiddos on medication. And then we're talking about, I'm going to see you a month from now. Absolutely not. I see them after I prescribe. I see them in 2 weeks. I want to know about side effects. I want to know how you feeling. How does it feel in your body? Like, do you notice any difference? And do we need to do something different with it? And when you have those partnerships and those relationships where the parent knows that they're just not given medication and they're on an island and no one is communicating with them, it is so robust. The kid knows when I see Miss Takesha, I'm going to tell her that thing gave me a headache and I'm not taking it no more. And Miss Takesha's going to hear me out and we're going to try something else. When you establish those trust and relationships, the whole treatment plan just goes a lot better.
And then how long can someone expect to be on it?
So, I mean, I've had kids on it for years because they need it, because that little boost really does help them. I have not had kids that I've taken off of it for because it was so effective that they just did so much better on it. Usually it's because of some sort of side effect that I had to discontinue and start something else. But I will tell you that I had a little guy that was really, really, really struggling to the point, I think he's about 9 years old, where he had to be removed from school. And the parents were adamant, no medication, no stimulant, non-stimulant, no medication. And when I first saw him, I had to see him in the parking lot because he was just so, and I was just like, oh, this is really, so in school, at home, same behaviors. So I talked to mom and dad about the treatment plan. And we talked about the stimulant. We went over the side effects. I told him I will see him in 2 weeks. You have my email. I'm responsive within 24 hours. And this is the thing. If you say it, then do it. If you say I'm going to respond in 24 hours, respond in 24 hours. Take time to just, give them what they need. So we put him on a low dose. It was only 2.5 milligrams of Adderall, and it was the immediate release. Within probably like a month, just at 2.5, got him through at least a half a day of school, where he wasn't going to school at all, a half a day of school. Sent the follow-up Vanderbilt. The teacher's like, yes, we're doing great. Right around 12 o'clock, my guy is wearing off. And so then I talked about it. Well, what we could do is go on a longer acting stimulant that lasts them throughout the day, or we can give them a second one in school that'll carry them through the rest of the day, see how you feel. But those are the conversations that we're having. If you explain, and then they see, wow, what she said actually worked. He was in my office coloring on the floor. We're in the office now. We're not in the parking lot in the snow. He's in the coloring on the floor. Thanks, Miss Takesha. Okay. This is, so when they see the results, and now we got this kid in school and now he's learning. I mean, and it's not perfect. And I tell my parents that too. I'm not going to change your child. Like, I'm not going to make him 100% different. This is only to just kind of get him in check for the time that he needs to be. But if your kid is a runner, jumper, mover, he's going to be a runner, jumper, mover, just a little bit more subtle with the medication that I give him. The goal is not to change these kids. I tell them they're not broken. I'm not trying to fix them. I'm just trying to help them function in their environment so that they can be successful. So.
Wonderful. As we wrap up, what are 3 takeaways for our audience today? You shared such a wealth of information, and you gave a lot of helpful tips, and we'll include those resources in the description box too.
Excellent. So first, I would say the comprehensive assessments are so important. If you don't have time to do them, please refer these children out so that they can have a good evaluation and a proper diagnosis. Secondly, please consider the differentials. Like, please make sure that you're ruling out the anxiety, the home environment, the sleep apnea, which requires a sleep study, which is an overnight study and sometimes can be really traumatic for a kid. So just, rule out. And then, go to the communities where the need is the greatest and do good work, because we're all capable of it. And the reward is amazing, not financially amazing, but personally amazing. So, yeah.
And we have done one episode on sleep apnea. It's one of our most popular, to be honest. But the things that you said today made me think that we need to do an episode on pediatric sleep disorders. That's a really important one for us to discuss. And lastly, how can people connect with you?
Okay, so I am Dr. Takesha Leonard, nurse practitioner in psychiatry, PLLC, located on the east side of Buffalo, 2495 Main Street in a Tri-Main building, suite 466. I am here. I'm available. Phone number 260-9320-716 area code. You can reach out anytime.
I love it. I love the old school, just saying out your number. That's very New York too. My grandmother used to tell me she used to leave her number every single time she left a voicemail. Grandma, we know it's you. You left a voicemail. It has your number. It doesn't matter every single time. But Dr. Leonard, we cannot thank you enough for your lending your time and talent today, but for your passion. You can't make that up.
Thank you.
You did a beautiful job today. You certainly helped a lot of people, and we're so excited that you've decided that you've allowed us to share you again on a second episode where we'll hear your personal journey on how you got to be the Dr. Leonard that we just got to witness. Remember, everyone, you can email us your questions and show ideas to tmi.melanin@gmail.com. If you haven't already, this is your chance to subscribe. Leave us a comment or two and share it with the people that you know. Every time you interact with our content, it shows the algorithm that this information is important, so that when people like you look for topics like this, we'll show up higher in their search results. At the time of this filming, we release new videos on Sundays at noon Eastern on YouTube, LinkedIn, and Facebook, and we drop the audio at 5 a.m. so all our night shifters can be the first to get something and not the last. We thank you all for watching. We'll see you next time.